Harley. I'm a health educator for perinatal reproductive health and will be your host during this session. For our technical support, Kamisha Busby will be assisting. Before we get started, we want to check in and provide a few reminders. This session is being recorded. For better quality, audio quality, please remember to mute your mics on your computer or phone when you are not speaking. Handouts for the training have been distributed to the registered participants before the training. If you have not received them or are in need of handouts, please email mchtraining@health.ok.gov and they will be sent to you. mchtraining@health.ok.gov. During the session, feel free to ask questions during each presentation at the discretion of the presenter. At that time, if you can unmute your microphones. If this is not an option, we have a chat feature within the meeting application. Feel free to use this option during each presentation as questions arise. Each presenter will allocate time during the presentation to address those. As a reminder, attendees are to complete the verification of attendance by way of the individual sign-in form. The link to access the form will be placed in the chat. This enables DNMs to easily verify your attendance for this Title X mandatory training. And might I add, we have updated our system for submitting reports, and when you click on the hyperlink or the QR code, it's going to take you to a questionnaire that has a hot air balloon. That is the correct form. And once you hit submit, it will say successfully submitted. So there's no need to resubmit it. And may I ask, or may I mention that if you accidentally put in the wrong date or a little detail, I can fix it on my end very easily. Don't resubmit something if you've submitted. If I have a question, I will email you for clarification. For example, this morning we had about 10 people to 15 people that I needed to communicate with out of 250 plus people. So that was really good. So please submit your documentation for attending as soon as possible. We would like to thank Susie Gibson, Amy Foster, and Rebecca Levinson for presenting today. Susie Gibson is presenting information about child abuse, neglect, and reporting. She serves as, if I'm wrong, the director of the Office of Child Abuse Prevention at the OSDH. Susie, we will now turn the floor over to you.
Thank you. Appreciate it. So I just want to, again, first of all, say I apologize. My camera is off, but this morning when I turned my camera on, my mic kept switching off. So there's a little picture of me, and that's recent, so you can see what I look like. As Iris said, I am the director I'm the program manager for the Office of Child Abuse Prevention. And in my office, we have Parents as Teachers, which is a home visitation program. We work with families that are either prenatal or have children through kindergarten completion. Families can enroll at any time. And we work with families on connecting them with community resource, concrete supports. We have a curriculum where we work on parent-child interaction, school readiness. So if you have any families that you think would be good for our program, let me know. And the other program that we have is the Oklahoma Family Resource Network. We just recently were able to establish 3 contracts across the state for family resource centers. We have one in Tulsa, one in Norman, and one in Oklahoma City. So the family resource centers are meant for families to be able to come in whenever they have a need. We are very flexible in our funding. So for example, I just learned about this today. We had a family that found themselves homeless all of a sudden, and they needed a place to stay. So we were able to secure a hotel for them for enough time for them to be able to secure other housing. So no one ended up in a homeless shelter or out on the street, especially with the children. So I thought that was kind of cool. very different way to support families. So that's what we do. If you're interested in learning any more about my office and the services we provide to families, feel free to reach out and I can hook you up with the coordinators of both those programs. So anyway, what I will be doing today is talking to you about child abuse and neglect reporting for the health department. We'll be focusing specifically on the 333F form. And I am going to go through each section of the 333F. So if you have used this form several times, used it before, bear with me. The reason I decided to do that is that I am the person that receives most of those reports, and I am starting to see where sections aren't complete or maybe not understood. So I thought it would be very helpful to go through each of those sections with you today. So if you'd like to move on to the next slide. So the purpose of the OSDH reporting policy is to assure that children are being appropriately cared for and protected, and to assure that the employees and contractors, I don't think there's any contractors on the call with us today, but this also includes contractors, are making necessary reports in compliance with state laws. Next slide. And Kamisha, thank you for being my slide person. This is so helpful to be able to have someone do that for me. Who must report and why? So Oklahoma, we are all mandated reporters. That's a law in our state. So every person, private citizen, or professional with reason to believe that a child under the age of 18 is a victim of abuse or neglect by a person responsible for the child's health, safety, or welfare. So one of the things that my home visitors do is when they enroll a family and they go visit a family, that's one of the things we tell them about, is that we are mandated reporters in Oklahoma. So not only are we as professional reporters, but also parents are reporters themselves. Okay, next slide. Abuse defined is harm or threatened harm, including but not limited to non-accidental physical or mental injury, sexual abuse, sexual exploitation, neglect, failure or omission to provide, protect from harm or threatened harm, and abandonment. Next slide. Neglect defined is failure or omission to provide adequate food, clothing, shelter, medical care, and supervision, or special care made necessary by the physical or mental condition of the child, or abandonment. Slide. So person responsible for the child could be a biological parent, an adult living in the home, person with custody, such as a foster family, or a child care provider. Next slide. So how to report. I'm sure you guys all know this, but you contact the DHS hotline, the 1-800 number, and we do not report anything to a local county DHS, which, as I had said this morning, a lot of the DHS buildings, the brick and mortar buildings, are closed now. They've moved to a very virtual existence. So a lot of counties don't even have that anymore. Next slide. When to report. If you suspect child abuse and neglect, please report promptly. If the child is in imminent danger, report immediately. If immediate physical danger is present, contact local law enforcement in addition to reporting to the DHS hotline. And we ask that all reports be made within 24 hours. Next slide. So failure to report, this is part of the Oklahoma Child Abuse Reporting and Prevention Law. Any person who knowingly and willfully fails to promptly report any incident may be reported by OKDHS to local law enforcement for criminal investigation, and upon conviction thereof shall be guilty of a misdemeanor. Obviously, I got that out of the law because I wouldn't know how to write something like that. So that is part of that law. Next slide. Immunity from liability. Any person reporting in good faith and exercising due care in the making of a report will have immunity from any liability, civil or criminal. And I'm under the impression Kamisha is going to send this PowerPoint to you. And you'll see the immunity from civil and criminal liability. That's actually the link to the statute. So if you'd like to refer to that, you have that link that's embedded in the PowerPoint. Next slide. So here's the form that we're going to spend the bulk of our time discussing. So I put it in this so you can see on the second page. This is the most recent version of the form, and a couple things to look for to know that you have the most recent is the revised dates. You'll see that the new Oklahoma State Department of Health emblem, seal, whatever that thing is called, that round, colorful thing, is on there. And then you'll also see that the body map has check boxes on it. So next slide, please. So the form 333F is to be completed immediately after a report is made to the hotline, except the follow-up section at the bottom of the form. So we ask that you complete the form to the best of your ability. And if you're approximating the age of the child, place an A for approximate beside the documented age. And this kind of came up this morning, so I wanted to make a point of clarification. Although we really hope that you can get as much information as possible and complete this form, we don't expect you to get the form out and ask it as in a questionnaire type format. This is if a family comes in and self-reports, or you see suspicious bruising or marking on the child and you feel like you need to make a report. This isn't us actually interviewing them using the form. It's just listening to objective and subjective information, and based on what we gathered, fill out the form as best as you can. Next slide, please. So when and who does this form? So the top of the form, the first box is you will document the date and time of the call made to the hotline. Record the name of the person accepting the report. So the person accepting the report is not going to be the same person that's assigned to the report. Obtain a referral number from the person accepting the report. And then next slide. I'm getting ahead of myself. So the next section, there's radio buttons where you can answer yes, no, or not applicable. This form is completely electronic. If you want to fill it out on your computer, you can do that and then print it off and mail it. Or if you still like to do things by hand, you can absolutely fill this out by hand. So the radio buttons, the questions asked, did the situation impose imminent danger to the child? If the child was in imminent danger, was law enforcement called? And this is the only question that has the option for not applicable. And was this report made anonymously? So that piece is important to know. That will tell me the reason that you don't have a referral number is because the report was made anonymously. Next slide, please. So reporter information would be your name, your position title, the county, the phone number, email address, and city, and at which health department or contract agency do you work. Okay, so you complete all that information, and then the next section is check boxes where you actually can check which service you're in. So this lists Children First, child guidance, family planning, immunization, parents as teachers, STD clinic, WIC. And then there's also, in case your service is not listed, there's a button for other, and then you just fill in what service you're with. Okay, next section. So the next section is the child victim information. So the questions are the name of the child, date of birth, age. This is if this a section if you approximate their age, making sure you document an A next to the age so we know it's an approximate. race, ethnicity, gender, and then you will use checkboxes to indicate if the child is physically or developmentally disabled. And if you do have the information, you can tell us what the disability is. And then the address or location of child at the time of the report. You may or may not know that information. Next slide. So this is the family caretaker information. So something to note here, you will list the parent, caretakers, and siblings. If you suspect that child abuse and neglect is not only happening to the child that you're actually seeing that day, but the siblings are also suffering from child abuse and or neglect, you'll have to fill out a 333F on each one of those siblings if you have the information. The next checkbox is for the primary language in the home address, phone, alternative phone, if they have one. Most of us don't have that anymore, but it's still on the form. Finding directions. This could be helpful to DHS if the family's in a rural area and the GPS, sometimes the GPS doesn't recognize some of those streets. So it could be helpful if they want to go do a visit with them. Next section, out-of-home care. I will say that on most of the 333Fs I get, this section is never completed. But if you do have the information, you can complete the type of out-of-home care, the address, phone, and alternative phone, who's responsible for the child, and the name of the school or child care center. You might be able to get this information regardless of out-of-home care because they may be attending school or child care. Next slide. The next section is the incident information. So you're going to use checkboxes to indicate the type of suspected maltreatment. So the choices are physical abuse, sexual abuse, emotional or psychological abuse, or neglect. So if you check one of those, then the description is next is what you provide. So you will check yes, no, or unknown for domestic or intimate partner violence in the home, dangerous substance involved, or are there dangers in the home such as it says dogs, weapons, meth. I don't know that all dogs are dangerous, but maybe sometimes there's a dangerous dog. I don't know. And then the description of what you, any information that you have been given about the environment and the type of abuse. Okay, next slide. So there's a very small space for a written description of the nature and extent of the child's injuries. So you can put it in that space if you want. I was under the impression this space was supposed to expand, but I don't think it does because sometimes I get these and this print is so small, I need a magnifying glass to see what it says. So you are welcome to attach either your progress notes or a different document if you have some narrative that is not going to fit in this small space. So you can do it either way. It is recommended to indicate a report was made in the file of record, but use the 333F for the documentation portion. But please check with your records consultant for details on that. Excuse me, next slide, please. Body map. So this is our pictures of the hands and the fingers and the face and the trunk and the body. And we were able to add check boxes in there. So if you do see any markings or bruising on the child, you can use this body map to kind of illustrate where you saw something that was suspicious. Next slide. And then underneath that, there are check boxes where you can check the suspected types and or indications of maltreatment. So this isn't just what you saw, but it's also maybe what was reported to you from the caregiver or the child. And there's also an area to check other if it's not listed here. And then below that, there's an area for narrative that you can describe what other was. Next slide. The form can be completed electronically or handwritten. We ask that you try to use blue or black ink so it's legible. After the follow-up section is completed, make 2 copies for the appropriate entities. One for my office, which is the Office of Child Abuse Prevention, or the acronym is OCAP, and then for the file of record. It used to be that we had it in triplicate, but that's when you were actually mailing a copy to DHS, which we do not submit it that way to them anymore. Make sure that each copy is signed by the reporter. Next slide. So the follow-up section. This is the #1 section that when I get a 333F that I have to get back in touch with the reporter to get them to complete this. So the follow-up section is done 1 week after you've made the report to the hotline. So you can call the DHS hotline and obtain the needed information to complete the follow-up section if you have the referral number. If you don't have the referral number because you made the report anonymously, please indicate in the section that says additional comments that you made the report anonymously and you don't have the referral number. So you're actually going to be putting this in 2 spaces. In the very beginning of the report, where you can check that you made it anonymously, and at the 1 week follow-up. This just helps us know, that gives us a double take of the fact that the report was made anonymously. Next slide. So you'll see here's the 333F again. I put a red box around the follow-up section so you know which section I'm talking about. Okay, next slide. So you may get an email or phone call from the OCAP, that's my office, if there's a question or the follow-up section is not completed and we don't have any indication as to why that's not been completed. If the reporter calls the hotline and the report was screened out, the follow-up section, hold on. The follow-up section still has to be completed before it's sent to the OCAP. If the report was screened out because there's already an open case on the family, please document that in the additional comments section. That way we'll know that if we read the 333F and we're like, wow, I can't believe this was screened out. Oh, okay, now I see why, because there's already an open case. That just helps us know that that family is getting the resources that they need. If the reporter is anonymous and is unable to complete the 1 week follow-up section, please indicate that, as I said, in the 2 places, the first box on the document and the additional comments section of the 1 week follow-up box. Next slide. And this is just my little disclaimer here. It is always up to the reporter whether the report is made anonymous or not. I probably should have worded this a little bit different. And what I meant when I added the supervisor in there is if you were to go to your supervisor for support when making this report. So you don't have to get permission from your supervisor to make the report. I was just trying to illustrate that if you and your supervisor decided it was in your best interest to keep the report anonymous, that's just kind of what I was saying. So there's nothing on my end that says you have to leave your name so you can get the referral number, but we encourage you to if you can. But if you don't feel safe, then absolutely it is totally up to you how you make that report, if that makes sense. So documentation summary. You should have a copy of the 333F. Again, that can be filled out electronically. It's a PDF. You should have the memo, which is the child abuse reporting policy in 333F form. You should have the OSDH administrative policies and procedures. And then I also included Title 10, Chapter 71, which is the Oklahoma Child Abuse Reporting and Prevention Act. Next slide. So information for the reporter when you do your 1 week follow-up. Although child welfare cases are confidential, you are allowed to know the name of the caseworker investigating, whether the case has been assigned or screened out, the number of days the caseworker has to work the case. That's just for your information. That's not something that we collect on the form. And how the case was ruled, screened out, assigned for investigation or assessment. Next slide. On the day the report was made to the hotline, you can email the 333F to the STO hotline referral inbox. You don't have to have the 1 week follow-up completed when you send it to them because they're going to know that information. We don't know that on our end. So after the 1 week follow-up is completed, then you will mail the copy to this address, the Family Support and Prevention Service at the central office. And you will also keep a copy for the file of record at the local health department or agency where the family was seen. Yes, LaWanda, I am so sorry. Last night, I kind of went down the rabbit hole and looked at my PowerPoint and decided I wanted to add in some extra slides to really go through the 333F because of some of the things I've seen when I get them submitted. So Kamisha is going to send that to you with the updated slides. So thank you for pointing that out. When you are sending a 333F to the central office, go ahead and either write or if you have a stamp on the envelope that it is confidential. Next slide. So the remaining signed copies should be filed in the administrative section of the client's child's medical record. And the progress note should be made stating that the ODH form 333F is completed. Again, the documentation is on the 333F, not in the client's file. If the child is not a health department client, a medical record should be opened for that child. Next slide. A file should be established to contain reports made on behalf of children whose names are not known. But everything that I just said, please check with your records consultant because they may have a different method for you to do this. So this is just the information coming from central office, but everybody has their own nuances. So I want to make sure that whatever you do at your county health department is what your records consultant wants you to do. Next slide. So this is my new slide. In addition to the other new slides, but this is my best slide. I have some exciting updates to come. We are really looking at this form and scratching our heads and saying, we got to get up to date here and get with the program. So we're trying to, and we're working on it right now, where we are creating the 333F form in a Qualtrics format. So it'll be electronic. And the hope is when you complete that form, you'll hit the submit button and it'll go to DHS for you. You don't have to email it yourself. It'll automatically go there. And then it'll still be there when you go back in for your 1 week follow-up and then hit submit again and it'll come to me. And that way you don't have to find a stamp and an envelope and fill all that out. So we are also determining the relevance of the information as well as using the form for data collection to show reporting trends. So we're looking at this saying to ourselves, this is really long. And what do we do with all of this? And what's necessary and what's not necessary? So when I say we, I have a team. It's not just me. But so far, we do have our first draft of the 333F. So obviously, we have to go through the chain of command to make sure everything's above board and everybody likes it. But hopefully in the next amount of time, I'm not even going to say how many months because I don't know because we're the health department. Sometimes those things you just can't predict. But once all of that is done, We will develop a comprehensive training that will go along with it that can be accessed via Health Hub. And you can access it at any time. And anytime you may need a refresher or you're wanting some additional information and you need to go back through the training. So our goal is to make your life a little bit easier around this form and develop a package that includes all your reporting policies, training materials, and related documents. So you can access it anytime whenever you're making a report. Because I know sometimes it can be nerve-wracking when you do it. So we want to be able to provide something to you where you feel very supported whenever you have to make a report. Next slide. So if you need to ever have a consult, if you want to talk to us about anything, if you feel like you need some legal advice, there's the legal counsel inbox right there. And you can also contact either me, I'm Susie Gibson, or Connie Frederick. She's the program manager for Children First. And she and I kind of work together on this project. And so either of us can definitely either answer your questions or send you in the right direction if we don't have the answers. Next slide. So that is it for me. Does anybody have any questions I can answer? Okay, I surely appreciate your time. Thank you for letting me come and occupy your afternoon. I realize I ended a little early. I'm sorry. I don't know how you're going to fill it, but I apologize for that. So I will make the PowerPoint longer next time.
Thank you, Susie, for sharing with us today and this morning and both this afternoon on child abuse, neglect, and reporting. We understand that it is our duty to report when we see a situation where child abuse or neglect is present. Again, just a reminder for all attendees, please fill out the verification form. It's the sign-in sheet, which is done via QR code in the chat or a hyperlink. Just a quick update on that. We have, as of now, about 185 people have filled in the sign-in sheets out of roughly 235 people that are currently on the feed for this conference. So please submit them as conveniently as soon as possible. Next, we have Rebecca Levinson. Is that who's speaking next?
Yes, she is logging on at this time. Yes.
Okay. Okay. Rebecca is an independent consultant and works with Futures Without Violence. And for those of you that use these, the INE published list, there are some brochures, one brochure in English and Spanish that is from Futures Without Violence. In this role, she assists in providing education and support around intimate partner violence, interventions, and support. And we will hear from her when she connects. While we're waiting for her, have any of you had any glitches in signing into the video conference, submitting your registration, at least attendance by QR code or hyperlink? Okay, well, when this video conference is over, I will then send the DNMs from each region. I'll take a snip of all of the attendees and send it to the DNM today so that she knows who attended today's meetings and she can follow up with those of you that did not attend.
All right, Rebecca's here.
Rebecca, we've already introduced you. So I'll let you carry on from here. Thank you for joining us.
You're on mute.
Sorry for that.
Can you hear me now?
Yes.
Okay, perfect. So I'm gonna share my screen. And Kamisha, you tell me if you can see my slides.
We can see them. Thank
Okay,
you.
great. Well, hello, friends. Rebecca, I hail to you from California, and this is the second time I've had the opportunity to speak to folks from your community today, so I'm excited to be with you. By way of background, I was staff and then I've been a consultant for Futures Without Violence for 22 years now. It's a long time. And if you aren't familiar with us, we're the U.S. Department of Health and Human Services for the feds, meaning our job is to listen to you and bring the latest and greatest research, white papers, innovations, and help you think about how you can robustly meet the needs of survivors, do primary prevention with both, but as well as trafficking. And I know you had, or you're going to have more information on trafficking today. So let's talk about our journey. We're going to understand the definition and prevalence of intimate partner violence. And that's what I stands for my friends who are always trying to unpack acronyms like I am. We're going to talk about two different person's reproductive health. We're going to name 2 contraceptive methods for a person experiencing intimate partner violence that they can use without their partner knowing it. And then ideally, and I'm most excited about this because this is our evidence-based intervention. We think that it is where the whole field needs to move. I'm hopefully going to make a very compelling case to you as to, and I know that there are many different providers on this call. So I know the bulk of you, Title X reproductive health providers, and then there's some home visitors and maybe some other maternity care people and maybe some primary care folks. And so what you should know is that while today is a little bit more focused on reproductive health, we have tools, modules for any comers. So if you're a behavioral health person, I'm going to touch on that for maybe a second today, but if you're interested in more, I'll be showing you how to get that moving forward. And the last thing I'll say is that prior to working for Futures, I actually worked for Planned Parenthood. So I've only had 2 jobs in my career. And at Planned Parenthood, everything from starting out as a clinic volunteer to doing health education to doing our CQI. And eventually I became the clinic director of 3 sites, one of which was a Title X site. So today's information is very near and dear to my heart. It's the blending of the 2 worlds that I've been a part of. Okay. I don't know about you. I got a phone call and I was running to getting to this webinar because I think you ended up finishing a little bit early. So recognizing that maybe you just jumped off a call, stepped out of clinic, I want to just give us a second to ground ourselves and be here together today in this space. And you might want to do that as taking a deep breath. One of the tricks of the trade in terms of grounding yourself is uncrossing your legs. That's my legs when I'm sitting. And if you actually push your heels and the balls of your feet on the floor, put your hands on your knees, lean in, take a breath. That's actually a grounding technique you can use when you're in front of a client and maybe something is disclosed that rattled you. And so it looks just like you're shifting your posture, you're crossing your legs, we all do that. And you're leaning forward toward the client, we all do that too. But in that process of intentionality, as you're pushing your feet into the ground, that you're taking a deep breath, you're going to find yourself with more capacity to take care of yourself because chances are your heart rate went up when a disclosure happened, etc. And also be able to be present for the person in front of you. So thank you for doing that with me. I would be remiss if I didn't begin with all of you, because bless your hearts, you take care of a whole lot of folks in your communities. And when you take care of people and when you are open to hearing about stories of trauma, being hurt by a partner, being forced to have sex by someone you didn't want to have sex with, as you hear those stories, so we know that healthcare professionals develop vicarious secondary trauma through the exposure of their patients' stories. And I want to just share one thing that I'm hoping, again, that can kind of change the national landscape. We knew before COVID about 50% of doctors were completely burnt out, and then COVID hit. And we've seen a huge number of clinicians, nurses, physicians assistants, can't do this anymore. And one of the ways to remedy this is to change your clinic policy so that you can see and hold your staff. So when there is a difficulty creating a space, actually, I wouldn't even say when there's a difficulty, because it sounds like you'd only want to do these meetings and do these reflective practice groups when there was a crisis. But in fact, every week, don't you? You have something that's hard. And so the idea that you carve out a half an hour, 45 minutes, an hour, so that people can come together and share their experience, it makes, right? So this is a cost-effective way to help staff with work in a judgmental environment. It provides regard and caring. You know, you'd want it to be regular and reliable, so monthly or bi-monthly. And frankly, it improves team function. It provides space for reflection, and it helps to reduce burnout. So as I mentioned, Futures has many, many tools, and we have, you know, hours of training on just how to take care of your staff if you're interested. What is intimate partner violence? I often think that people go to the image of a black eye in their head, bruise, maybe strangulation marks around the neck. But we know from a public health perspective that there are all these ways in which power and control show up in patterns that affect your health, your safety, and your well-being. So while physical violence is maybe the first place people go, I think it's important to note that emotional abuse, being told you're worthless, all of those things absolutely in fact impact your health, mental health. I want you to think for a second about economics. I grew up in rural Colorado on a dirt road. My mom was unfortunately in an abusive relationship with my dad. So what did he do when he was mad at her? Took the car, because there was no public transportation. There was no way out. She was trapped. We were trapped. And so I think these pieces around how power and are all things that can affect your ability to take care of folks, and I think require some innovation in terms of thinking about it. So for example, you know, if you've got a partner or a person coming in to see you, and let's say they've missed 3 appointments in a row and they're a depot user. Now, did they miss those 3 appointments in a row because they're non-compliant, irresponsible, etc.? Or did they miss those appointments because their partner took the car away from them and wouldn't let them get there? And when we start thinking about how power and control shows up, I think it allows us a different lens to hold the space that's happening around the folks we serve, and kind of move out of judgment and move to a place of curiosity and wondering about what else is going on that you can't see. How prevalent is intimate partner violence? We know 1 in 4 women will experience this her lifetime. We know this from the Centers for Disease Control, and that high violence, it says 18 to 24 here, but there's just a paper that came out, and I'm afraid I didn't change the slide, looking at highest risk ranges 16 to 24. So I think that's worth noting. My friends who are working with adolescents and women in their early 20s. I also think it's really worth pointing out that we know LGBTQ folks experience some of the highest rates. That was my timer to get on this call, so forgive me, I hadn't turned it off. We see high rates. And so as you're thinking about, well, how do I create a welcoming environment for all comers who might be being hurt in their relationships? You know, do your practices reflect pictures of trans folks on the wall? Do you have posters? Do you have information? At Futures, we certainly do have posters, safety cards, that cues intervention we've talked about absolutely is tailored for LGBT and then trans and non-binary folks. We have 2 different cards there. So if you need more supports or tools on that, we're the people to talk. Okay, so Kamisha helped me last time because I can't see the chat box. So I'm going to ask y'all to take a second, dig deep, and think about how intimate partner violence impacts reproductive and sexual health. And I want you to think big. Think about, how does it affect teenagers? Are there reoccurring issues, so clinical issues that you might see happening over and over again? Are there problems with medication adherence? So I'm going to let y'all put things in the chat, and Kamisha, I'm going to ask you to translate for me, please.
So we have some starting to come in. Stress could cause birth defects, someone mentioned. There could be a possibility of unwanted pregnancies.
Absolutely. Yeah, absolutely. What else? My title 10 friends.
STIs.
Yeah. Same.
Birth
Thank
control
you.
birth control pills are being flushed.
Yep. Perfect. So I want to share with you, this was a really large systematic review of the literature, meaning they did a search for intimate partner violence and condom use, intimate partner violence and contraceptive use, and they pulled together all the literature on those 2 areas where power and control can show up. And here's what they found. The prevalence of intimate partner violence in the United States and its linkages with contraceptive use and unintended pregnancy. It can be estimated that 2.1 million unintended pregnancies have resulted from this synergy. What that tells us, and we'll be talking a little bit more about the concept of reproductive coercion moving forward, but what that tells us is for you all in reproductive health, the way power and control is showing up has everything to do with flushing those birth control pills, as some smart person put earlier, pulling off the condom, putting holes in condoms, breaking condoms, not condoms. And there's more where that came from. But I think when we back up and we can, again, it allows us to think differently about the kinds of conversations we'll be having with folks in clinic. And, you know, here's my humble pie moment. I will tell you, I worked at Planned Parenthood. It was really my first job and my only job before I started working for Futures. And I love teenagers. I have 4 kids myself. And I can remember negative pregnancy tests. And if you were 15 coming into the clinic and you had a negative pregnancy test, that little bag of condoms, which is what you see right there, the blue condoms, they're going to go into that paper bag. I somehow gave you like the extra big bag, not that you asked for it, but I just made it for you. And I put lube in there, and I probably was really funny about, you know, maybe demonstrating how to use a condom because this was a young person. And I wanted to make sure they understood all the pieces. And here's my place my heart hurts. I assumed when someone came in for a pregnancy test and told me, I don't want to be pregnant right now, and I don't want to use any other birth control, I want to use condoms. I assumed that that was something they had decision making around. And, you know, occasionally when I would leave clinic, I would see one of those perfectly folded little brown bags full of condoms in the trash. Okay, why? And what do you want to think about that clinically? You know, what if you read a step of condom education as a conversation about, can you ask your partner to use one? Because I didn't ask, I assumed that they could. And chances are some of you have done the same thing. And so what we're doing right now is we're pushing ourselves past our assumptions and recognizing that that power and control that's showing up that prevents our client being able to contracept successfully is something that to the bottom of from the get-go, from the starting gate. I will say the same thing about expedited treatment options. We were so excited when that happened. I'm old enough that there was an expedited partner treatment, and then there was. And we were like, woohoo, we're just going to make sure that everybody has that chlamydia treatment in their hands. They can give it to their partners. We're going to tell them to abstain, use condoms, all the things we do. Except, what if it wasn't safe to tell your partner you had chlamydia? Did you stop and ask first? I didn't. All right. So maybe some of you are wiser than I am, these longer than they were in the early 90s for me. But I certainly going back in time, I would ask clients if it was safe to talk to their partner about using them. Are they worried about anything relative to that? The other thing I really want you to think about is, I know that when you have a positive syphilis, HIV test, chlamydia, gonorrhea, that we have to let the partner know if we know who the partner is. And Bedside has actually some interesting ways so that it can be done anonymously if it's unsafe for the client to be the one that tells the partner. So my friend Liz Miller and I did the seminal study on sexual coercion. A lot has changed since then. This was published in 2011. I think we were doing the research in 2009, 2010, maybe even as early as the end of 2008. And what at this through the lens of adolescent health, I was coming active health, and we both were thinking about power and control in relationships. And so in a nutshell, reproductive and sexual coercion are behaviors to maintain power and control in a relationship related to reproductive health by someone who is, was, or wishes to be involved in an intimate or dating relationship with an adult or. And when we break it down a level further, right, we're talking about explicit attempts to impregnate a partner against her wishes, interfering with contraception. We're talking about controlling the outcomes of a pregnancy. Now in 2011, as big as we were, moving forward, what's missing from this definition? People in polyamorous relationships who don't necessarily see themselves as in a single intimate relationship, but have multiple relationships. What else is missing from this definition? People who are experiencing trafficking. They may or may not be in a romantic relationship or a sexual relationship with the person that's trafficking them, but certainly the person that's trafficking them can be engaging in coercion. So what do we do? How do we fix it? And when you think about power and control relative to forcing someone to get pregnant when they don't want to be, what is the abusive partner watching when you get your period? And so methods of contraception, like Implanon, like the Mirena, things that change your bleeding patterns or stop you from bleeding, etc., might be a tip-off to a partner who's trying to get you pregnant, things up, right? And so what we were always thinking about is, how can we give them a harm reduction that keeps them safe that their partner doesn't know about? And we landed on the copper T IUD because you get your period at the same month, and you can clip the strings in the cervical canals. Abusive partners pop out pills and throw them away. We also know that they pull off patches, pull out rings, all of those things. And, again, from a harm reduction perspective, the inconvenience of an IUD removal with an be worth avoiding an unwanted pregnancy by an abusive partner. And, and you can imagine how if you're in this controlling abusive relationship, the last thing in the world you need is an unintended pregnancy on top of that. So I mentioned the IUD. The other thing that we did as a harm reduction strategy is emergency contraception. And I will tell you, when we were doing the study, Plan B came in a big pink box, and it was very clear what it was. And what we ended up recommending, based on what clients told us what would work for them, we'd ask them, so this big box has EC on it. Would it be helpful if we gave you a little envelope to drop the pills in so that anybody who went through your purse couldn't find it? Oh, yes, that would be really helpful. Or, oh, I have this little teeny pill thing. I forgot I have it, and I can put them in my purse that way. The other thing that we would recommend, because we know that reproductive coercion is not a one and done. It's not a one-time thing. It's something that probably will keep happening extra emergency contraception in those cases is so. I mentioned to you again about bedside in order to get information about how to do harm reduction relative to partner treatment notification. Okay, I've been talking fast and I'm going to slow it down again because this is not for you to put in the chat. This is just for you to sit with yourself. And hey, my friends on the phone or on this webinar, if you're uncomfortable with the disclosure of intimate partner violence, you are not alone, okay? So, you know, there may be some of you who are between 4 and 5. Super comfortable, you've been at it a long time, you've had multiple positive disclosures, you have a relationship with your local DV agency, and you kind of know what to say. You figured out like how to say the comforting things. You have those scripts in your head or in your back pocket and you pull them out. Some of you are in the middle. You're like, well, I have had a disclosure, but I wasn't totally, you know, there in the way that I wanted to be. I didn't feel totally comfortable. And some of you are in the red and thinking, please, oh, please don't say anything to me about what's going on. All of those are fair. You know, friends, chances are maybe you're a survivor. Think about hearing someone's story on top of your own experiences, which is, again, why I gave you that grounding exercise in the beginning. Maybe it's because you're a newbie. Maybe you haven't had training on this. Maybe it's the first time you've had training on this. So of course you're not going to know what to do, what to say, and where to go. And that's really what we're here to support today, is the shift into a place of a little bit more green or a little bit more blue. So notice where you are, because I'm going to ask you to check in when I finish the talk today and see if the needle moved for you. Okay, so Kamisha, I'm getting ready for another chat box question.
Okay.
And the question that folks are going to ask is the why. So let me read you the top part. How many of you have personally or know someone who's ever left something out of a medical history or intentionally misreported information to their healthcare provider? I'm just going to make this fast. All of us have known someone or have done it ourselves. But the question I want you to answer together is why? Why don't people tell us their stories? Why do they change things in their medical record?
Feel free to write your answer in the chat or unmute your mic. We have one started, judgment, stigma,
Right?
embarrassment, shame,
Mm-hmm.
afraid of judgment,
Yep.
a lot of embarrassment,
And you know,
unsure how to approach it, fear.
if I say it out loud, it'll make it true. Yeah, and then one that I hear that's missing right now is for any of you who are working with folks that are parents. There is a great deal of fear around a disclosure of intimate partner violence triggering a child welfare report. It's really well documented in the literature. That's a real fear too. So I want us to think about what we do now. What we do now in most health settings is we do something called screening, right? We ask a standardized question tool, or maybe the client's filling it out on some kind of electronic health record. But we ask a question like, have you been hit, kicked, slapped, or choked by a current or former partner? And I want you to think back to what you all just said, all the reasons why I'm not going to share that information with you, even if you ask me directly. I'm not going to. And so that leaves a huge number of hurting people behind. Right? You're the gatekeeper for information. And it makes sense to me. If someone says, nope, not experiencing that, you're going to go on and say, okay, was there a family history of high blood pressure or whatever your next question is? Because they said no. What it takes for them to get information about local resources or support or all of those things is a yes to that question right now. And if we're thinking about health equity, if we're thinking about the most we are leaving the folks that are hurting the most behind. And I don't think we can keep doing that. I don't think it's ethical. I don't think it's right. I'm not telling you to stop screening if it's a requirement of your program, but I am saying that each one of you in every setting that you're in can do universal education to promote health equity And this is the moment that we need to shift gears. What does universal education do? It's a strategy to treat clients with respect by giving them key information about healthy and unhealthy relationships and where to get supports without just requiring disclosure. So think about that for a second. That is a radical change from what we do. What percentage of your patients say yes right now to IPV? Is it 2%? Maybe 4%? Maybe? Yet you saw in the opening that it's 1 in 4 women who will experience intimate partner violence in their lifetime. So it's 25%. And I would say in family planning clinics that are federally funded, we've seen as many as closer to 50%. So it's a huge thing. And it's very simple. So here you see CUES intervention. I mentioned at the outset, CUES stands for confidentiality, universal support. You can see hanging out and hooking up is a card that's directed at teens. Sex, pleasure, and choice. The choice is actually about making choices with your body, like around consent, etc. So I just wanted to point that out. So these are things that are multi-panel cards. They're really small. They're the size of a business card. And they talk about healthy and safe relationships and ones that aren't. Kamisha, did you have that video queued up, or I'm just going to skip it if you don't?
I have it up, but if you could let me know which section, like, do you know the number section of where we need to start?
I totally do. So I'm going to escape, and I'm going to stop sharing my screen. Okay, stop sharing. So on slide 20, you are going to fast forward to 2 minutes and 34 seconds, and we're going to let them see the video if it works on your end. And if not, we'll just skip ahead.
Okay, perfect. I got it ready.
Great. 2:34.
Monthly, quarterly? Likely, based on the research, most of you are seeing very low disclosure rates. We know young adult women using family planning clinics report higher rates of IPV compared to their same age peers, in some settings as high as 53%. So we know IPV is taking place at much higher rates than clients disclose in our settings. Research shows that about 64% of transgender individuals report sexual assault in some point of their lives. Let's consider why disclosures may be difficult for clients. Research tells us it's a myriad of things: feelings of shame, concerns about child welfare involvement, and concerns about judgment on the part of the provider. In rural settings, clients may have concerns about who will find out or confidentiality. Lastly, long-standing issues for clients of color that have experienced racism within the health system and have a distrust of medical services generally. Given the realities of low disclosure rates and recognition of the barriers for disclosures, how might we enhance the work we have been doing to address IPV in reproductive health? Universal education prompts providers to give information about and resources for IPV to all clients without first requiring disclosure. This approach normalizes the prevalence of IPV and how to access help for yourself or others. Let's look at a different approach that can enhance your IPV screening.
Before you go, I want to share these cards with you that I give to all my clients. I give everyone two so that you have information for yourself and so that you can share one with a friend. We all know someone who has struggled in a relationship and we weren't sure how to help them. So it talks about relationships and what we deserve in them: respect, kindness, no pressure to have sex. And it talks about situations with partners who may try to hurt or control you. Now on the back, there's a number for a free, anonymous 24/7 text line where you can text to get information or talk about relationships. Is this something that you'd be interested in taking a look at or taking a photo of?
Yeah, this is good. Yeah, I actually know someone who might really need this, so thanks.
In this session, we saw the provider offer information to a client up front without needing the client to disclose first. This is what we call universal education, giving information to all clients up front without requiring disclosure, since many people who could benefit from the information might not feel safe or be ready to disclose. It took about 45 seconds. Let's consider why this might be empowering for the client. What happens when we frame the intervention around 2 cards so we can help others? Research tells us that this approach normalizes the encounter for the client. By not having the focus solely on them, they can feel free to take the information, even if it is for themselves. We also know that treating clients as allies who can help others is something that can be profoundly beneficial and meaningful for our clients. The client feels respected by the provider, so this approach has multiple benefits. Every client gets resources they may use for themselves or may use to help others, and providers
Hey,
have a
Kamisha,
sense
we can
they
cut
may be
this.
increasing their own impact as a result.
Great. Thank you so much, Kamisha, for helping me run that. And I'm going to try to bring up my screen again, and I'm asking, can y'all see my slides?
Yes, we can.
Okay, great. See cues in action, which I'm excited about. And it was through handing these little cards. So this, I mentioned the 2 cards earlier that you can get from Futures. Oh, we're going to move past this. No, don't do anything. Just quickly, right, here's the overview again. We're going to see patients alone, not with friends, not with partners, not with parents, see them alone, talk about the limits of confidentiality, and you're going to go through the script and again, highlight the hotlines on the back of the card and touch on healthy and safe relationships and ones that aren't. Here's what the back of the card looks like. And you can see there's a QR code to get you to more information, free text lines, free chat lines, and information on Bedsider, again, to help them if they need information on reproductive coercion or they need information on safer partner treatment notification. Now, I have talked about universal education. That does not mean I don't think you should do direct inquiry in practice, right? So you got a client with a negative pregnancy test. I want to ask, is anyone preventing you from using birth control or wanting you to get pregnant when you don't want to be? STI. Anytime someone comes in with an STI, I want to understand if you can talk to your partner about condoms or if that's something you're worried about doing for any reason. So you've got to hear our narrator say, you know, what happens when cues is framed this way. It's, you know, this whole idea of bringing it into the context of helping other people was a game changer for us doing our research. And essence of cues is it truly builds relationships faster between the provider and the client. It's strength-based and caring focused. It improves access to advocacy. Remember, you're going from 2% getting information about the DV hotline to 100% getting information about the DV hotline if you do cues. It empowers clients and the folks they care about, and it shares power between the provider and the client. Now, while disclosure isn't the goal, we know that when you create safer spaces to have real conversations, that folks are more comfortable sharing things with you. So I want you to know and be prepared about what to do. Survivors tell us they want providers to be non-judgmental, to listen, to offer information and support, and to not push for disclosure. I think the biggest thing, though, I want you to hold on to is this. We are not expecting you to be experts in IPV as a result of a 40-minute training. That said, you have experts at your beck and call all the time, and you may not know that, right? So the DV hotline and your local hotline is also there for you. They can provide guidance or discuss cases, discuss and expertise. You know, I think it's super important for you all to sort of take something out of your thinking, because I think a lot of us are driven toward fix it. Leaving can never be our goal for a survivor, because we know that leaving a highest likelihood of homicide and acute injury. So sometimes the safest decision for a survivor is to stay. And what your job is to sit with that person and understand what they think is the best for them, because they've been surviving all of this time. They're the expert on themselves, the situation, and they have all that history of all the things that they've tried for harm reduction strategies. If you get a disclosure, here's some examples of what to say. It's not your fault. You're not alone. You don't deserve this. Thank me. Thank you for sharing this. I believe you. I'm so sorry this is happening to you. Okay, for my friends who are newbies, I don't even know what to say right now, but I'm so glad you told me. One of the things that I think makes a big difference, you know, if I were to talk to you right now about getting, and by the way, I've been getting my hair cut by Jenny Knight, her actual name, the last 26 years, long time. And if I told you, oh, you need a haircut? Okay, there's Supercuts down the block, or my friend Jenny Knight kind of can read you as you walk in. Do you need a glass of wine? Do you need tissues because you're going to cry? What do you need? So you're going to be more inclined, because I've given you a framework around Jenny, to go to her. I have a relationship and I'm vetting this person. So I'm encouraging all of you to think about developing a memorandum of understanding with a local advocacy program. You know, invite them to a virtual lunch and learn how they can support both clients and staff. Sometimes these folks even have, I mean, I partnered with mine when I'm back in the day when I was at Planned Parenthood. Our shelter was called Haven. And if we got something called a hot positive, meaning there was a client who wanted to disclose, that was in a really dangerous situation, that wanted to file a police report, wanted to do a restraining order, all the things, they would literally, if they had time, they would come and they would do that with our client on site, right? And in exchange, what we were doing as a clinic was we were offering birth control tests on site at their shelter. We were offering information on contraceptive methods, and we're able to provide contraceptive methods. Not all of them, they didn't have a table, but some of them. And it really changed. What ended up happening as a result of that nurse coming to provide information to all the folks in shelter, you could follow-up appointment. And now I have a warm handoff because I know what Nurse Pam is like. So, my friends, this is the work. And because so many of us come into helping professions to fix things, myself included, I just want to say you can't fix it. It's not yours to fix. All you can do is plant those seeds, and that's what CUES does. You don't know when that seed is going to sprout. Don't underestimate the power of listening and believing for someone who has extreme isolation. And then if you write down something for a sticky note for your computer or your cork board or your door, feeling helpless does not mean you're not helping. Feeling helpless does not mean you're not helping. Let's talk about the science behind the intervention. In our original study, we found there was a 71% odds reduction for pregnancy coercion in the intervention arm of the study as compared to the control. We also found in the intervention arm that women receiving the intervention were about 60 times more likely to end a relationship because it felt unhealthy or unsafe. You know, remember, control arm isn't getting cues, intervention arm is. And, you know, we weren't talking to folks about healthy and unhealthy as part of regular, you know, conversation question at Planned Parenthood. And we saw that there was a big difference between when we unpacked unhealthy, unsafe, what you deserve, all those things, that both groups of women left relationships. These were young women ages, I think it was 19 to 27. It's not that they didn't leave relationships, but it was the reasons they gave for leaving the relationships look quite different. We did this work with adolescents. We did research at a school-based health center and also at a teen young adult health center. We found that their sexual harassment victimization decreased from 65 to 22% in the school health center, from 26 to 7% in the teen health center. And then clients were overwhelmingly positive about CUES. 84% said they would bring a friend to the center if they were experiencing an unhealthy relationship. And I can tell you, when we were doing the study, I was there, and like every once in a while we'd have a teenager walk in with this card and they said, my friend said that you could help me. Wouldn't you like to be a part of that? Here's what providers told us. So these were qualitative interviews I had the honor to do. So one provider said the card made me feel empowered because you can really, that might have been afraid to say anything or didn't know how to approach the topic. This is a door for them to open so they can feel more relaxed about talking about it. And I think that holding of, hey, we talked to everybody about this. We give you the information for yourself, but also because we all know somebody who's struggling and we want to know how to help. And this can help with that. Here's what clients said in these qualitative interviews. They would bring out the card, basically walk in with it, and she would open it and ask me if I'd ever seen it before. It was awesome. She would touch on no matter what situation you're in, there's something, or I don't have to be alone in it. That was really huge for me because I was alone most of the time for the worst part. Another client said, getting the card makes me actually feel like I have a lot of power to help somebody. So a little bit of a journey together today. And I just want to kind of remind you that growing strong partnerships with DV advocacy programs not only benefits your clients, it benefits you. I hope I made a really strong case why you'd want to use the CUES approach versus screening alone. That we reach everyone with CUES, and we reach such a few number of people when we screen exclusively. We want to screen people alone. We want to offer patients supportive messages. We want to make warm, supportive referrals to DV advocacy and consider IPV for your differential diagnosis. If you've got a frequent flyer coming in for pregnancy tests and she says she doesn't want to get pregnant, bing, 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 maybe she's not able to make decisions, or her partner promises to use condoms or doesn't. And that is the opening to have a different conversation about, did you know that there are methods that your partner doesn't have to know about? Because for some people, you know, it's really hard, or they feel unsafe, or they feel comfortable talking about it. And there's some strategies that maybe you don't know about. Okay. So this is just for you. Think about Arrow a little while ago, and I'm hoping it moved a little greener. If you're interested in ordering cards, you're going to go to the store at futureswithoutviolence.org. We do charge a $15 flat fee to ship, but you can order hundreds of cards. My friends who are in home visitation, my friends who are working in primary care, my friends in LGBTQ populations, we have specific cards for you. My friends who are working in behavioral health, my friends who are working around ACEs, adverse childhood experiences, and parents and children, we have cards for you too. So that there's so much more where this came from, and all of it is the same sort of flat fee, and we can send you cards in bulk. My provider friends, if you're interested in knowing more about the research, about how to create that MOU, more about the science relative to how IPV affects your health and well-being, or trafficking, because we certainly have that as well, you go to ipvhealthpartners.org. And I will end with this. This was the interview that I did that stays with me always. She's under my skin. Yeah. So there'll be times where I just read the card and remind myself not to go back. I'll use it so I don't step back. I'll pick up on the subtle stuff because they'll trigger me. I remember what it was like. I remember feeling like this. I remember going through this, and I'm not going to do it again. For me, it just helped me stay away from what I got out of. I carry it with me, actually. I carry it in my wallet. It's with me every day. So thank you for all you do. I really appreciate, and I'm going to stop sharing my screen so I can see folks or look at the chat. Thank you. And if folks have questions or things that are coming up, please let me know. And Kamisha, if you've got anything, you please go.
Oh, no, you're fine. So Rebecca, thank you. If you have any questions, comments, or anything you would like to leave for Miss Levinson, please unmute your mic or place those in the chat. So I will, Shauna, the question, can you send the link for us to order the cards out to us as well? I'll have all of that information
Okay,
in
great.
a follow-up email for all of the learners post-training. There's a lot of thank yous. There's a thank you, Rebecca. This was very insightful and provided ways to think about reframing some of the discussions around this topic. So thank you.
Well, you
My
are so
apologies.
welcome.
Go ahead. I'm sorry. My apologies for my voice. I'm a little under the weather, so it's in and out with these changes.
Oh.
In Oklahoma, you know, the pollen and the wind and everything else is dusting up here. So you all don't see that quite so much in California, sunny California, but here in the Midwest, the winds do sweep down the plains.
Well, you sound pretty good to me, and I just want to thank my friends in Oklahoma for taking the time and caring. I appreciate the thanks, and I'm hoping it inspires you to think differently about, you know, some of the things that you might not have before. So,
All right.
anything
Ira,
else,
we'll
or-
turn it back over to you.
Well, Rebecca, I want to thank you for, as I mentioned earlier today, for letting me impose upon your life and seek you out as a presenter for here in Oklahoma. And your topic goes right in with our next speaker and with the general topic. And I want to thank you for sharing from your wealth of personal experience as well as expertise that has many practical points that, you know, that we can apply to our setting, our situation. So you gave, I think, a lot of good information that can fit in, not only in the health department setting. We could meet someone on the street that also is in need of that passion and care.
Well, if you don't think I don't have those cards in my wallet and in my glove compartment, you're wrong. I do. And it certainly isn't something I only do in clinical realms. It is something I do is just because we see stuff. We see stuff in the grocery store. We see stuff on the street. We see stuff all the time. And if we really want to think about how we can contribute to changing the world a little bit, right? And the idea that we're giving this to clients and they can take it and use it in their church, in their community, in their community center, with their babysitter, with their, you know, early childhood teacher. Didn't we just make the world?
Well, it's been awesome. Thank you so much. Well, we now have Amy Foster, who's one of our staff here that works with us. Amy is a nurse practitioner consultant for the Perinatal Reproductive Health Division within the Maternal and Child Health Service. She'll provide information on human trafficking, resources within the state, and strategies for clinical staff to navigate if faced with this challenge. Amy, we'd like to hear from you now.
Well, hi. So like you were saying, I do work for MCH and I see most of you guys. A lot of the times I'm going out to the clinics to cover for providers or doing site visits. I'm going to share my screen now so I can get my PowerPoint up for you all. And I am very happy to share this important information with you guys today. If you have any questions during this presentation, you know, feel free to unmute, or I will give you a chance at the end to ask questions. There are also a few points when I would really love your input. If you'll just answer back to me or give me, you know, some things that you guys do in your clinics, I would love that. So let's get started. So, you know, why is it important for us to talk about human trafficking? It is one of the fastest growing crimes in the world, with over 30 million people estimated to be enslaved. So most trafficking involves sexual exploitation. Here's a good definition of exactly what sex trafficking is. It's the recruitment, harboring, transportation, provision, obtaining, patronizing, or soliciting of a person for the purpose of a commercial sex act in which a commercial sex act is induced by force, fraud, or coercion, or in which the person induced to perform such an act has not attained 18 years of age. So here's my first question for you guys. True or false? If you can just type in the chat or unmute. Human trafficking is always or usually a violent crime. Right, I already see the correct answers coming in. Okay, let me see, fix my camera a little bit, I'll try. Yes, it is false. So, you know, a lot of people believe that human trafficking, you know, is going to be, you know, violence and something that comes from someone, you know, that involves kidnapping or physical forcing someone into doing things. But that is one of the biggest myths about human trafficking. Most traffickers use psychological means such as tricking, defrauding, manipulating, or threatening victims to get them to do what they want. Next question. All human trafficking involves commercial sex. True or false? Yeah, thank you guys. False. So I am talking a lot about sex trafficking today, but the truth is human trafficking is the use of force, fraud, or coercion to get another person to provide labor or commercial sex. Worldwide, experts believe that there are actually more situations of labor trafficking than of sex trafficking, but there is a much wider awareness of sex trafficking in the US than labor trafficking. True or false? Last question. Traffickers target victims they don't know. Right. False. Thank you. That is false. Many survivors have been trafficked by romantic partners, including spouses, and by family members, including their own parents. So people may be vulnerable to sex trafficking if they have this in their history or, you know, as a part of their life. A history of domestic violence, have a caregiver or family member who has a substance abuse issue, are runaways or are involved in the juvenile justice or foster care system, are undocumented immigrants, are facing poverty or economic need, have a history of sexual abuse, are addicted to drugs or alcohol, have an unstable living situation. Now, definitely many of our clients face at least one or more of these. So is this happening in Oklahoma? And definitely the answer is yes. So these are statistics that I pulled from the National Human Trafficking Hotline. In 2021, which is the most recent statistics available, the hotline identified 99 cases of human trafficking here in Oklahoma, and 180 victims were identified in those cases. Now, since 2007, the Human Trafficking Hotline has identified 887 cases of human trafficking and over 2,000 victims right here in Oklahoma. That is as far back as they have been making these statistics public and collecting them. So family planning clinics play a vital role in identifying and treating victims of trafficking. This includes making sure the clinic is as safe and secure as possible for victims, knowing about reporting trafficking, which is one reason we're doing this presentation today, offering services and resources to meet the victim's additional needs, and providing follow-up appointments for any further services required, creating a welcoming and trusting atmosphere so that victims feel comfortable, adopting a protocol to help identify and respond to trafficking victims, using a victim-centered trauma-informed approach during intake, medical history, and examination. So examples of sex trafficking: prostitution, in which there's any force, fraud, or coercion; prostitution of children less than 18, no force, fraud, or coercion required; and pornography. When I was researching this, I thought pornography, how is that involved? But they just said that, with the increasing sexualized culture, there's been a link to increased human trafficking because they're using victims to make pornography. The Title X family planning staff are first responders, and we have a unique opportunity to intervene and offer assistance and resources. So, a lot of these signs that I'm about to go over and warnings, they come, first start happening when people make their appointments. So everyone from the front desk, the schedulers, and then the staff in the back of the clinic, can notice these signs and become aware of them. So some of the first signs are no identification, no identifiable address or home, and then escorted or guarded or silenced by someone, disorientated, age inappropriate partner or significant other, signs of physical abuse. Usually you'll start seeing that later in the appointment, signs of self-harm, and then fearful behavior. And it's great if you do identify some of these at the front desk or when they're making an appointment to just make sure and pass it on to the staff, who takes them to the clinic and starts going over the medical history. Here is a link at the bottom of this. My next slide will show you. There's a great little print off that you can hang at the front desk, just a checklist to kind of remember to look for some of these things. Now, if they just have one of these, depending on what it is, like if they don't have a driver's license, or if they live with friends, that doesn't necessarily mean, that they're in sex trafficking or human trafficking. But if they have multiple of these, it's definitely something to start thinking about. So during the medical and history exam, there are many signs and indicators of trafficking that may be revealed. The goal in the exam room is to build trust so that your client feels safe enough to disclose what's happening to them. So I have many stories of survivors, and this is my first one. And, I know this content is really tough to hear, tough to talk about. So if anybody needs to talk after this or anything to someone, I understand that. But this first story is that the clinic was the first place that seemed to actually see me as a person. The nurse saw that I was frightened and listened to me. It was the first time I thought about telling someone what was actually happening. I don't think that we can underestimate, just giving someone the time and really listening to them and helping them feel safe. Many of our clinics have protocols in place. We do have protocols in place that are helpful in identifying victims of trafficking. One of the key things that I know we always try to do is examine the client alone. Sometimes the person with the client, it takes us kind of standing up to them and saying, but we really have to do it this way. It's best for the client's confidentiality and privacy. This is our clinic protocols. However, if the client is insisting or you think they might leave, it may be necessary to allow that other person in the room. And just as a reminder, make sure that they fill out the consent form OSDH number 206. But, we would rather them get the care they need than to leave because they can't bring someone in. But if we can encourage and kind of act like it's our idea that they can't, hopefully if it's the other person trying to force the issue, we will be able to get to see them by themselves. So there are many signs and indicators that might be revealed just in your patient's medical history. Multiple of these, could be an indicator that they are involved in sex trafficking. Multiple sex partners, multiple unintended pregnancies, multiple miscarriages, abortions, STDs, multiple types of contraception use simultaneously or serially, multiple uses of the abortion pill, multiple uses of multiple UTIs, and then a history of substance abuse or homelessness. So these are definitely things to look for during the physical exam. Signs of physical abuse, injuries from violence or hazardous work conditions. You know, if you have a patient telling you a story of stuff that happened at work or how they got an injury and it just seems really unsafe or unusual. Gynecological complications such as cysts, fistula, and vaginal fissures. PID, vaginal injuries, bleeding or tissue damage, foreign objects in the vagina, anal injuries, bleeding, tissue damage, dermatological issues such as scabies or lice, signs of self-harm, scars from repeated cutting, attempt suicide or suicidal ideations, malnutrition, dehydration, signs of substance abuse such as like needle tracks, specific tattoo markings. I don't think that we would necessarily know because so many of our patients have tattoos, but there are traffickers who will brand patients with certain tattoos to let other people know that they are theirs. Serious communicable diseases such as hepatitis or TB. So it is really important that we use strength-based, non-stigmatizing language and methods with our patients. Survivors have often talked about how they don't even have any idea how many sexual partners they've had. They're scared that providers might shame them for their number of sexual partners. I like this example I found. Like, this might be a better way to ask that question than how many people have you ever been with? You know, how many sex partners have you had? Just saying, have you had more than 6 sexual partners in the last month or even in the last week? A trafficking victim may have complex trauma. Even a simple exam could trigger fear, flashbacks, and other trauma reactions, which we'll talk more about. And just always try to make sure and use clear language, not real technical medical language. It could be confusing. Here's another survivor story. I was 12 when I was trafficked. My dad was a preacher, so I came from a very conservative home. I didn't even know there were 3 different openings down there. I got an STD the first time I was sold, but I didn't know what was happening. I wish I had come to the clinic. I wished when I came to the clinic that someone had taken the time to explain my body and what was happening to me. I think this story was just a great reminder that some people have no idea what's happening to them, and they don't even know what questions to ask, or they're too scared to ask them. So it's just remembering to take the time to make sure they understand what's going on with their bodies, how they got their STDs. You would assume that they'd know, but just like the story said, never good to assume. So, you know, it is important to create an atmosphere of trust and care that supports the clients to feel safe and disclose what is going on. Many clients are going to have barriers of their own due to what they've been through, distrust of others due to feeling betrayed by partners, family, or other community members, difficulty being aware of and understanding their human trafficking experiences and feelings of stigma, shame, and guilt can be really overwhelming. They may have emotional attachment to their traffickers, which could be really confusing, and the other victims that they are, you know, housed with. Fear of retribution from the traffickers, including harming their family and other loved ones if they tell what's going on. Fear of being complicit with an illegal act and not aware of their legal rights. So they could be scared of going to jail for the illegal activity they've been a part of. Fear of authorities and officials of any kind, including deportation, law enforcement, and healthcare providers. Fear that reporting could lead to return of their abusive home, jail, or foster care. Experiencing a transitory lifestyle, being forced or needing to move frequently. Victims may have had previous interactions with healthcare providers that were stigmatizing or shaming, leading to trauma. It is critical to provide victim-centered, and compassionate family planning services. So, as family planning staff, we may face some barriers also, such as limited knowledge about human trafficking, including understanding of federal, state, and local laws. Limited opportunities to understand and identify adverse childhood experiences, complex trauma, polyvictimization. a busy clinic schedule that allows little time for identifying and responding to victims of human trafficking, preconceived notions of how a victim of trafficking presents, limited access to professional interpreters and or materials written in varied literacy levels or multiple languages. You know, luckily we do have a lot of interpreters in our clinics, and we always do have the language line available. And lack of or limited referral options, which that is just true. When you're in rural Oklahoma, it is a lot harder to have the referral sources that we have here in the city. I'll talk more about that later. And I do have some different numbers for you. And also even like the national human trafficking line can help link with resources. And then fear of violating HIPAA. So a victim-centered approach requires patience, empathy, and compassion from the entire staff. Everyone from the scheduler and receptionist to the clinic and the counselor or the social worker. So what does a victim-centered approach mean? Ensuring the victim's concerns, safety, and well-being take priority in all matters and procedures. Seek to minimize victim re-traumatization by providing support to victims through victim advocate and service providers. Focus on the needs and concerns of the victim to ensure the compassionate and sensitive delivery of services in a non-judgmental way. You know, I know this is our goals in the clinic, and I think, you know, staff do a wonderful job at doing this. Here's another survivor story. I had bruises on my body when I came to clinic, and they did ask me if I was safe, but I wasn't going to tell them that my pimp beat me. Why? Because I wanted to live to see the next day. So, you know, this is just a good example of like, why don't people get help? Why do some people just not tell? And a lot of times it is fear. So this is the first time I'd love some participation from you guys, either in the chat, which Kamisha is watching. I can see it sometimes when it first pops up, or just unmute and you can talk to me about it. But what do you guys do in your clinics, you know, to help create a safe, trusting environment for the client to feel comfortable opening up?
I think something you can do, and this is really more just when someone's walking in, but having resources available and like they can see them just right off the bat, like this is a safe space. Like if you have a hotline available or any information about intimate partner violence. So just walking in, I know, okay, this is a place that recognizes that their clients could be going through that.
Yeah, I love that. Yeah, I think that, oh, sorry, go ahead.
There's another one in the chat. Ask that only the client come back for the examination. Have a warm greeting for them and be open with them.
Yeah, like if we smile and, you know, say hi to them when they come up, I feel like that's a really different thing than if when they come in, we don't even hardly make eye contact and just hand them some paper to fill out. And I love that about the resources. That does immediately give them an idea that this is going to be a safe place. And even the National Trafficking Hotline, I saw on their website that you can order like little cards and stuff to have laying out that they can, you know, so they can have that number, which we can talk more about later. Show them that we are prepared to listen to them. Exactly. There's so much we can do with our body language and stuff to help them see that. Okay, here's some more things, and you guys covered a lot of them. Identify yourself, make eye contact, explain how you can help, make all interactions respectful and considerate of cultural differences, actively listen, which is exactly what someone said, show interest and let them speak for themselves, try not to put words in their mouth, empathize. Empathy encourages a relationship of trust. Do not rush the client. If they are confused or angry or don't know all the answers to a question, just be patient. Ask open-ended questions to guide the client to tell their story. Open-ended questions are important. And limit the number of people that they have to tell their story to. If they are talking and if they are explaining something bad that's going on, you don't want them to have to tell everybody that. So if you're the nurse in there in intake, you can definitely tell the provider what's going on where they don't have to repeat the whole thing. If you're at the front desk and they start telling you, you can definitely notify the staff so they just don't have to start from the beginning. Offer to connect the client with other support services. That's so important. Just like our speaker before was saying, none of us are, I'm not an expert in this. There are experts that I know how to get connected with. So just knowing those resources are so important. Encouraging return visits or follow-up for additional help. And I did see one more in the chat. Oh, confidentiality. That's right. I'm talking about how this is confidential. I will just bring this up again later. I always, when I'm talking to someone less than 18, say this is confidential unless you're in imminent danger. But that's right. Just reminding them that this is a safe place, and especially if they're adults, you will not have to report. So this is the next question for you guys. And Kamisha, I'm sorry, I see something in the chat, but I can't read it all. Do you want to tell me what that is before I move on?
Sure. As a community health worker, the nurses will come to me and tell me if they have concerns and ask me to speak to the client, then ask the client if they need any resources and information or sooner care. I am just friendly with them and even give them a choice to leave the door open or closed. Usually, if they decide to close the door, they're about to open up, and they sometimes just feel better and safer with someone to talk to. And then there's some other one came in, give the patient an opportunity to have a moment to themselves without rushing them to leave, making resource information very visible without forcing it on the patient.
Yeah, that is all awesome. And I love that with our community health workers. I've heard how great they are and what all they're doing in our clinics, and that's really awesome. Okay, thank you guys for responding. I love to hear what you guys are doing in your clinics. That's great. And it gives good ideas to other people. I like the idea of saying, I can close the door if you feel okay with that, and I can see how that can give them. I love giving patients control in their appointment too, and it can help them feel safe. Okay, so when someone does tell you about being abused or intimate partner violence, or if they are involved in sex trafficking or human trafficking, what are some ways to respond to your patients when they tell you something really sad, really scary that they're going through? I will start, and then I'll let you see what you guys have to say. Recently, I was doing a well woman exam on a patient, and she just was so nervous. And she told me, like, this kind of stuff makes me so nervous. And then she said that she was raped in the past. And, immediately I said, I'm so sorry that happened to you. Do you need any resources? Are you safe now? And we kind of talked about that. She's currently seeing a counselor, and it was a few years ago, and she's not around that person anymore. And then I just told her she was in control of this visit, that I was there to help her get the medical care that she needed. However, if she ever needed me to stop or she needed to take a break, just to let me know. I also explained that it was completely normal to be nervous. Especially because of what she's been through. And I just kind of showed her everything that I was going to be doing and just, took it one step at a time. So how have some of you guys responded when people have told you, that they were in an abusive relationship, they were in a sex trafficking situation, things like that? That took a lot of, yeah, that took a lot of courage to share that with me. You're safe now. I'm sorry to hear this happen to you.
I'm
Will
here
you
to
read?
listen. I'm here to listen and give and assist you in trying to get some help. That's what the rest of it says.
That's awesome. Yes, that's great empathy.
I'm sorry that you're going through all of this, but I will help you in any way I can.
That's awesome. That's just such good empathy and so much compassion. First one on my list.
Listen, don't act shocked or surprised by what they're saying, even if it is shocking. Ask if you can help with any resources, like you said. If it's something serious happening right now, then encourage them to speak with our social worker.
Yes, for sure. For sure. Those are great. You know, thank you for trusting me enough was the first one on my slide, which you guys said. I'm sorry this is happening to you exactly. We can treat you right now for your infection and get you additional help for food, clothing, shelter, legal assistance. Many of these resources are free. Would you like me to call them from here? Or would you like me to call them for you? Like if they do want to call the police? Okay, Kamisha, I'll let you tell me some more that are in the chat. Were there a few more? I think there were a few more that came in. Hold on, I'm pulling it up on my phone because I think I can see it.
Please know I'm not judging. Ask if they want an STI testing or pregnancy test, but don't pressure. Make sure to give them power.
That's right. I love that. Give them power because so many people who've been through trauma and, you know, they've been victims, they lost their power in that situation. And that's exactly right. You try to give them their power back. I love that. They have choices here.
So, Amy, there is a question. Bobby has asked, I haven't had this experience yet. However, I am concerned a person in need would hesitate to talk to me. Any suggestions on how it could make them feel more comfortable? And
Yeah,
this is a male.
okay. Yeah, and I mean, I agree. Like I think sometimes being a male might make it harder just to be honest, even though, you know, I know that might not be right, but sometimes women might be reluctant to open up. But I would just say if you see some of these warning signs and stuff, you know, to definitely pass it on to other people in the team that are going to be also seeing them. But I think just for me, like sitting down, not standing over them, making eye contact, you know, showing care, telling them, you know, like if they need any resources, that, you know, you have resources. And I think at sometimes you'll just get kind of a feeling that they're scared or like something's going on. Just kind of trust your intuition and make sure and offer them resources. But I think just showing a caring, you know, compassionate attitude goes a long way with people. And, you know, like our previous speaker said, like maybe even if they're not ready to talk about it this time, maybe just seeing the resources we have or knowing there are times when I've had patients that I am just sure something's going on, but they aren't saying anything. You know, with my people under 18, I always say like, you know, are you in a safe environment? Is anybody making you be here today? Is anybody forcing you to do anything you don't want to do? And if they're like, no, you know, I'm like, well, just remember, this is a safe place to come if you ever need a safe place, if you ever need resources or to talk to someone. Okay, so it's important to avoid blaming, shaming, or further traumatizing the patient, which none of us would do on purpose, for sure. But these are just reminders of things not to do. Using derogatory names such as prostitute, promiscuous, bad decision maker. Avoid making negative assumptions or quick judgments. Do not exhibit abrupt, curt, or dismissive language or behavior. Don't blame the victims for the crimes committed against them. Avoid pressuring or threatening to talk to a client. Do not say whatever is happening to them is all in their head or due to stress. Avoid assuming that a pregnancy is unwanted. Do not exhibit negative body language, poor eye contact, crossed arms, defensive posture, taking other calls, or typing or writing while the client is trying to talk to you. Cultural norms have to be taken into consideration. You know, sometimes people don't want to make eye contact and stuff, and that has to do more with their culture. So here's another survivor story. I was trafficked when I was a child, but trapped in it for years. I had a very violent pimp, so many beatings, so many injuries, so many illnesses. I went to dozens of emergency rooms, urgent care clinics, and doctor's offices. It seemed like I was just a body to be poked and prod and fixed. I still remember going to the family planning clinic and having a nurse just put her hand on me, just touch me as a person and say, it's going to be all right. I'll never forget that caring response. And again, I just want to remind you what it says at the bottom, you know, some people aren't comfortable with touch, but I feel like when you've worked with patients for a while, you know, and you can feel when they are. And sometimes it can mean a lot. So not everybody wants touch, but go with your intuition and your care and love. It goes a long way. Most trafficking victims have extensive histories of physical and psychological trauma. Any response to suspected human trafficking must be trauma-informed. I love this video, but we can't watch it today because it's an hour long. But if you ever have time to watch it, the link is here. Because there are a lot of people, unfortunately, who have experienced trauma that are going to be coming into our clinics. 1 in 4 children experience some sort of maltreatment, physical, sexual, or emotional abuse. 1 in 4 women have experienced domestic violence. 1 in 5 women and 1 in 71 men have experienced rape at some point in their lives. 12% of these and 12% of these women and 30% of these men were younger than 10 years old when they were raped. This means a very large number of people have experienced serious trauma at some point in their life. Medical exams, by definition, can feel very invasive. Exams often involve asking sensitive questions, examining intimate body parts, and sometimes delivering uncomfortable and even painful treatments or procedures. It is important that healthcare providers are mindful of the fact that many people come to their healthcare interaction with a history of trauma. Whether it is a single event or multiple events, major trauma can significantly change a person's body and physical responses and the way people view themselves, those around them, and the world in general. Thoughts, feelings, and belief are affected, and these drive behavior. People respond to traumatic stress in a variety of ways, ranging from withdrawal and depression, anger, aggression, anxiety, inability to pay attention to extreme expressions of emotions. While trauma can affect anyone, regardless of their demographics, it affects certain populations more due to historical and systemic oppression and discrimination. This list includes refugees and asylees, migrant and seasonal workers, opportunity youth, which is people like 16 to 24, not working, kind of trying to figure out life. American Indians, Alaskan Natives, Native Hawaiians, and Indigenous people, the LGBTQ community, people with physical or cognitive disabilities, and survivors of violence. So, what are some of the things that you can do to make patients more comfortable during their visit? We've definitely talked about some of these. This can be while they are being questioned about their medical histories or actually during the exams procedures. So what are some things you do to help make people more comfortable during their visits? I touched on a few of these when I was talking about, like, you know, making eye contact, sitting level with them, or even sometimes I'm a little lower when they're on the bed. But like I go in and I sit down and I talk to them before I just immediately start examining them. Yeah, tone of your voice, calm, reassuring, and non-judgmental. Your voice and the way you say things can say a lot to a patient. During the exam, I talk my clients through the process. Will you read the rest of that for me?
So they know what's expected next.
Yes, definitely. That's a huge one. I think that can really, really help people with their anxieties and, you know, decrease their stress when they know you're not going to do anything without telling them. Here's some more. Ask your patient if there's anything you can do to make them more comfortable. If the patient seems really anxious about a procedure or what you're about to do an exam, I usually offer them to turn on music on their phone or watch TikTok, just anything to distract them. And just like that comment in the chat, use the tell, show, do modeling. You're telling them what you're going to do. A lot of times I even show them the speculum. I show them my pat brushes because I think sometimes they think you're going to, like, you know, take a piece of their cervix or something. So I just show them, like, it's just these brushes I'm getting the cells with, and let them know you will stop. This is that thing about giving your patient the power that we were talking about. I think it's so important. You know, you're in control. I'm going to stop if you want or need me to. What was the other thing in the chat?
It was again a CHW here, but I will honestly always joke about the weather first, then go from there most of the time, just starting out our chat off with humor to ease the room.
Oh yeah, that's great. That is great. We have someone on our team, Nikki, that does that all the time too. I love humor. I think it definitely puts people in a lighter little bit mood and just kind of a good way to start off for sure. Okay, so we've all had patients that we thought were not responding appropriately. So possibility that trauma underlies a client's unexpected or unusual behavior, especially if that behavior appears maladaptive to the current situation you're in. Just thinking about the potential function of that behavior, and maybe just a protective mechanism. Importance of transparency, informed consent, and respect. So whether they laugh when we're trying to do a pelvic exam or just extremely rude or hostile, it is important to remember that sometimes these are their coping skills, or it's because they're so anxious or scared to be there. Of course, it's not okay for any of us to be treated badly, but sometimes having grace and showing compassion will help them get the care that they do need. Sometimes even asking, what can I do to make this easier for you? You know, I have definitely had patients that seemed angry when I came in, and I just like kind of stopped and sat down and been like, you know, you seem upset. Is there anything I can do? Do you want to talk to me about anything? Do you have any questions or concerns? You know, before we even start this visit, is there anything I can do to make this better for you? And then explain everything you do and get consent that it is okay with them to proceed. So there are many things that could cause fear or stress for people who have experienced trauma. Having to lie down for treatment, objects used during the exam, fear of flashbacks, fear of authority, fear of being touched, fear of pain, anxiety regarding potential diagnosis. And I will tell you guys, I have a story. It makes me sad every time I think about it. I told it this morning, but I was really new into my being a provider. It was probably first few months on my own. And, you know, I had a 30-year-old patient, didn't seem nervous or scared about the PAP at all. You know, I'd gone in and talked to her starting my exam. Everything seemed fine. No warning signs, nothing. I, you know, put in the speculum and like literally the bed was shaking, like she was shaking. And like she was sobbing, and I like looked and I'm like, oh my gosh, am I hurting you? Like, what's going on? Do I need to stop? And she was like, no, 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 please just finish. But she was sobbing. And you know, it was really awful. Like, I know I could feel it that I triggered something for her. You know, I finished very quickly, of course, covered her back up, let her get dressed, tried to come back in and talk to her. I tried to give her resources, ask her if there's anything she wanted to talk about. She did not. She was just upset. There was no consoling her. It was awful. It was my most extreme situation and for that ever, but I knew that it triggered something. And you know, so again, every patient, even the ones that don't seem nervous, because I feel like that's an unconscious bias, which we're going to talk about next. But you know, I just assume because of her age and like she didn't appear nervous. When I have a young person or someone who seems really scared, I'm more to say, I will stop at any time. I'm here to care for you. You know, you're in control of whether, you know, I continue or do this or not. And I show them the speculum and everything. But it's just like, that reminds me, like, every time we don't know what people, we have no idea what people have gone through, and they definitely don't always tell us. So it is important for all Title X family planning staff to identify and address their unconscious bias in order to offer the most appropriate services for victims of human trafficking. Unconscious biases are stereotypes about certain groups of people that form outside their conscious awareness. So, Kamisha, I'm going to ask you to show this video. Let me stop sharing my screen. Maybe. Okay.
Whether we are aware of it or not, both our slow thinking and fast thinking systems are always at work. Most of the time, they work together in positive and coordinated ways. They allow us to navigate complex environments and tasks, like providing family planning services in a busy clinic. But they each bring with them their own kind of bias. From our slow thinking system, we get explicit or conscious bias, which is a preference for or against certain categories of people. But conscious bias is voluntary and can be controlled. On the other hand, our fast thinking system gives us implicit or unconscious bias, which is an involuntary preference or inclination for certain types of people. It is something we have a lot less control over and is often unintentional. We may not even realize we're treating people differently. How does this happen? Well, throughout our lifetime, the unconscious thinking system automatically assigns people we meet to a particular class or group based on experiences, what we've been told, or what we are exposed to in the media. Over time, stored beliefs and expectations of people based on their group category are often unconsciously activated without even realizing it. We know that most people who work in family planning have made a conscious commitment to providing fair and equitable services. Providing family planning services requires a lot of subjective decision-making, which isn't easy. And our brains have to make decisions constantly throughout the day, such as, which questions should I ask next? How much information should I share? Should I provide everything today or ask them to come back? Our unconscious bias can cause us to share additional information, make exceptions for, and go out of our way for clients with whom we share interests or who we feel are similar to us. And we do the opposite for those who don't fit our own cultural norms and values. These subtle variations over time can cause some groups to have a lower quality healthcare experience than others. It's important to remember that biases don't make us bad people. They make us human. By realizing how our biases may be impacting other people, we can change practices and habits that unintentionally contribute to healthcare disparities.
Okay, let me try to get back onto the screen. I think there it is. I'm having problems with my mouse, sorry. Okay. Okay, So biases can occur with regard to race, sexual orientation, socioeconomic status, and lifestyle. Unconscious bias can impede the ability to offer the most appropriate services to victims. Examples include bias related to perceptions about client involvement in prostitution, judgments to whether the client is poor, unmarried, unable to care for themselves or their children, whether the client should be pregnant, or if they are pregnant, whether they should carry a pregnancy to term. There are many more examples. There are classes, one I recently took that was really great, that speak only about unconscious bias. We all have them. It is important to recognize what they are so we can provide better care to our patients. I heard someone explain it like this, and it was kind of in the video too, but it doesn't make you a bad person if you have unconscious bias. It just makes you human. So here's another survivor story. I was 16 when I came to the clinic for contraception. They saw that I'd been there before for vaginal infections. And they asked me about what I was doing. I told them my boyfriend was selling me, but said that I agreed and I was doing it voluntarily. They said okay and didn't ask me any more questions. Now, this is kind of a little complicated, a little tricky case. But the clinic did some things wrong. Does anybody know what's wrong with this situation? So if a patient tells you they don't want to report, yeah, age. Exactly. So if a patient tells you they don't want to report, if they're an adult, that's fine. And you can offer them resources. I usually tell them if they ever do, they can come back. This is a safe place. We'll help them. However, if they are less than 18, that is why with my minors, I always tell them at the beginning, anything we talk about is confidential. However, if you're in imminent danger, I do have to report it. So if they're less than 18, whether they are doing this voluntarily or not, it has to be reported. If they're over 18, or I'm sorry, if they're 18 or over, you can just give them resources or encourage them, Also, the hotline we're going to talk about, it's a really great thing to give people that maybe aren't ready to report, but just so they have and they can look at like the website and the things they offer. So, a lot of this was talked about before in our great presentation we've already had today. But you do treat it just like child abuse. If somebody is, admits that they are involved in this, or even if you suspect that they are, you're supposed to report, okay, if they're less than 18. Even if they say that there is already a case open, you still need to report. And I really like what she said earlier about always calling the 1-800 number to report. Don't call your local office. I actually had a patient recently who said she had reported this and stuff and nothing was getting done because her mom was like best friends with someone who worked at the local office, the social worker there. But anyway, interesting. So I did call the 1-800 number to report, even though she said it had already been reported. And then just a reminder, it's a misdemeanor or criminal offense to fail to report suspicions of child abuse or neglect. So Oklahoma does have a human trafficking hotline. This is not for someone that's in immediate danger. That's a 911 or calling the local police department. But this is a great resource to have. You can call them, you can ask them questions. They're kind of over that whole division and they can, hook you up with the right people that you may need to talk to. Patients can also call this number, but not for imminent danger. So next up we have Eva's story. Kamisha, if you'll please share that video for me. And this story talks about the Dragonfly House, which we'll talk more about, and I'll give you some more resources after this.
What first struck me about Eva was just how brave and determined she was, especially given the absolute hell that she had been through in sex trafficking as just a teenager. By her 19th birthday, and in just a few months of coming to the Dragonfly home, Eva had regained her footing. She had begun to see in herself her own incredible courage, and she was full of dreams for her new life. Eva's story is a good example of what sex trafficking can commonly look like here in Oklahoma. Her family didn't have a whole lot. Her mom worked around the clock just to make ends meet. When Christopher, a charming older guy, started hanging out with Eva and her group of high school friends, he purposely singled her out, pouring all of his attention on her, and this made Eva feel beautiful and important. Christopher made Eva believe he really cared about her and her family. He helped her family with groceries a few times, bought her little brother a new pair of tennis shoes, and even bought her a designer purse. But Eva couldn't have possibly realized his true motive, that he was making a small investment in her life so that he could make a much bigger profit off of her later on. One afternoon, Eva went to go hang out with Christopher, just like she had so many times before. But this time, he drove her to a hotel room, forced her inside, and then immediately raped her. He threatened her with his gun and demanded that she do exactly what he told her to do, or else he'd kill her entire family. That's when he started bringing men in, one after the next. Christopher had arranged for these men to have sex with Eva for his own financial gain. Eva was devastated. She was crushed, confused. She felt trapped, and she was unable to tell anybody about what was happening to her for fear of what would happen to her family. For the rest of the summer, Christopher posted ads of her and sold her to strangers for sex. Thankfully, law enforcement saw the ads and they did an undercover investigation. They actually recovered Eva, arrested Christopher, and Eva was referred to the Dragonfly home. This is where Eva's experience in sex trafficking had come to an end, but it was just the beginning of a very long journey to restoration and healing. Eva came to the Dragonfly Home Human Trafficking Relief and Restoration Center, where we've served hundreds of victim survivors of sex and labor trafficking. Through our case management services, Eva had the opportunity to process everything that had happened to her in a safe place and begin sorting out everything she needed to be able to move forward. We worked with her to create a plan so that she could accomplish the goals that she set for herself. Eva's #1 concern was safety because of Christopher's threats towards her and her family. We worked with her to create a safety plan specific to her situation so that she could feel safer and that she would feel more prepared if she found herself in a dangerous situation. Eva also decided she wanted to do therapy. It's a brave step to work through trauma like that, but she did it. She put in the hard work, and with each session, she felt more and more hopeful that she could get through this. Eva also made the courageous decision to testify against Christopher in court. This is so hard, but with our court advocacy program, Eva felt more prepared and more empowered to help. With the help of her testimony, Christopher was sentenced and put behind bars. After that, it was like everything just clicked for Eva. Christopher no longer had the power to take anything else from her, and she wasn't going to let her experience in sex trafficking define her. This is the moment that Eva really began to dream again for herself, and she eagerly started working towards her goals, like learning how to drive, getting her first job, and saving for college. Eva continues to get support from the Dragonfly Home. She loves the survivor support groups where she's made friends who've been through similar experiences. Recently, Eva even enrolled in community college. This was a huge milestone for her. Eva really exemplifies our mission at Dragonfly. We believe that every victim survivor of human trafficking deserves freedom and the opportunity to pursue a new life. And our role is to walk alongside them and provide them with whatever they need to move forward. When people support Dragonfly, they're supporting people like Eva and so many other victim survivors of human trafficking as they walk toward their own future of freedom.
So I think that video is amazing. It's an amazing true story of someone right here in Oklahoma. It's hard to watch. And it does go back to what we were talking about the first of the presentation, how a lot of time this is someone she was romantically involved with, that she cared about, that she thought really cared about her. That takes it to a whole different level sometimes than how a lot of people feel like sex trafficking is just with people that it's forced or, kidnapping. So here are some other resources that I talked about. All of these places, the Dragonfly Home is amazing, and it is not like an overnight shelter, but all of these places have 24-hour crisis hotlines. And this is where I go back to that if you're in rural Oklahoma, I know it makes it harder, but they do have shelter numbers. They help people make plans on how to get out of trafficking safely, resources for medical care, mental health, spiritual support, referrals to shelters, and referrals to services or shelters for someone they know. So if it's someone that is concerned about someone who they know is in sex trafficking, they can call and get help from these places also. This is the big number that I saw that we could order cards and stuff from, to hand out. That might be great to have in our clinic, something we'll have to talk about, I'm sure. But they have it, and where you can also talk to someone or text in English or Spanish, which is wonderful. I was looking around at their website, and you can also, there's a quick exit button, which I thought was really cool. So if somebody, say they're not ready to report, but you give them this information, they can go to the website, they can look about the resources that are offered, and they can text and ask questions. So every engagement is a chance to help victims understand their bodies, articulate what is happening to them, and seek the resources they need. So just remember that, every time you see a patient in clinic, we don't know what they've been going through. We don't know where they've been. And I hope this training today is just a reminder of what to do in these difficult, scary situations. I feel if we get to help one person in our careers, then we will have definitely done what we're supposed to with our lives and made a real difference. And you all have a chance to help many. So anyway, you do make a difference. Thank you for taking time to do this training today. If anybody has any questions, let me know. And otherwise, I hope you have a great weekend.
All right. If you have any additional questions for Amy or comments, please feel free to add them in the chat or unmute your mics at this time. There's a lot of thank yous in the chat, good information. We definitely will love to hear your feedback, so please make sure that you complete the post-training survey. And Ira, I will now turn it back over to you.
Am I, okay, there I am, okay. Thank you, Amy, for sharing from your experience, wealth of experience, and then working in the County Health Department clinics as well with many of the staff. It's been a great day and a session to learn about child neglect, abuse reporting, interpersonal violence, and human trafficking. And also a big thanks to Susie and Amy who presented earlier. Please remember that this is a mandatory training. You do need all attendees to complete the individual sign-in sheet symbolizing participation. The link to the form is in the chat. For those who have access to SharePoint, you can find access there as well. And I just want to mention, I've been going through all of the sign-in sheets or documentation, and I just sent out documentation to all the DNMs of those who attended, and we pretty much had almost 100% sign-in sheets, plus or minus 2 percentage points for the entire training today. So thank you for being faithful and sending in your documentation. The next video training conference is scheduled for April 14th and will bring information on navigating behavioral and mental health post-pandemic for youth. You'll be receiving more information on this training in the coming weeks. Thank you and have a great weekend.